The masticatory system should be considered as a complex system, not as a biomechanical system focused exclusively on dental occlusion, because, in this sense, the occlusion is nothing more than a subset of the complex system, interacting with the other subsets, such as periodontal receptors, neuromuscular spindles, recruitment of motor units, central nervous system, temporomandibular joint, etc., to give shape to an emerging behavior, the masticatory one. The peculiarity of this concept is that it is not possible to interpret or predict the emerging behavior of a system by extracting objective data from a single subset. Instead, the integrity of the system must be quantified in its entirety, and only then can a segmentation of the whole be attempted to make an analytical description of the node itself. In the presented clinical case, the question is resolved in the following language logic. The subsets of the masticatory system, teeth, occlusion, temporomandibular joints, muscles, etc., are in a state of coherence of system with the central trigeminal nervous system. See figures 1b, 1c and 1d. So the term malocclusion cannot be used, the phrase occlusal dysmorphism should be considered instead. This does not mean abolishing prosthetic, orthodontic and orthognathic masticatory rehabilitation treatments. On the contrary, this forma mentis tends to restore medical knowledge to dental rehabilitation disciplines, as well as offering an alternative to the scientific reductionism that converges in a deterministic interpretation of the biological phenomenon. Going beyond the specialist perimeters of the disciplines, as previously reported on interdisciplinarity, helps expanding the diagnostic and therapeutic models, as it can be seen in the clinical case, in which a patient was treated with the OrthoNeuroGnathodontic method, is reported. 12-year-old patient who shows to the cephalometric examination underdevelopment of the jaw, which is small and not very projected, and imprisoned in the maxilla. The hypodivergent growth, also, determines a severe deep bite, that does not allow the eruption of the upper canines, in the presence of molar class 2. The trigeminal electrophysiological tests, not reported here, ensured that the patient, in the conditions in which he presented himself, for the OrthoNeuroGnathodontic treatment, was in a state of system coherence, such that the occlusal imperfection could be corrected through classic orthodontic masticatory rehabilitation. If the electrophysiological responses had shown neuromotor discrepancies, a state of system decoherence would have been added to the occlusal imperfection, to be treated with functional neuronathological therapies, to restore the state of system integrity. The cephalometric analysis showed a skeletal class 2 morphology, hypodivergent, biretrusive profile with SNA 80 degrees, SNB 75 degrees and ANB 5 degrees. The first phase of the treatment consisted in restoring the maxillary spaces and volumes, through molar distalization by means of NET open coil, nickel titanium open spring, between the first premolars and the molars, which allows to obtain, in addition to the recovery of the first molar class, also, the recovery on the sagittal plane of the space necessary for the canines. The use of class 2 elastics is essential to avoid the mesializing countervector on the upper frontal group, as well as the lip bumper inserted in the tubes of the bands in the lower molars, avoids the mesializing component on the lower arch, through the lip thrust on the resin shield. Figure 5 shows a fundamental passage in this type of orthodontic treatments, that is the need to control the increase in occlusal vertical dimension, generated by the occlusal crown rise bite, performed with composite resin on 14 and 24. On the right, in fact, we can check, extemporaneously, the response of the brainstem to the increase in the vertical occlusal dimension, and, above all, a physiological position of the occlusal centric. An asymmetry in amplitude of the jaw jerk, in fact, would indicate a spatial deviation of the lower jaw. Figure 6 shows the second phase of the treatment, which follows the phase of molar distalization, and which corresponds to the increase in the vertical occlusal dimension, with finalization of orthodontic treatment. Figure 7 shows the finalized clinical case, but it is essential to remember that in all phases of treatment, and even more, in the finalization phase, it is absolutely important to check the alignment torque, and the occlusal asymmetries, in order not to generate an incisal anterior wall, and occlusal interference, which, in an increase of the occlusal vertical dimension, could increase the spatial error in the intermaxillary relationship. As reported in the introduction of Masticationpedia, the evaluation of the central nervous and peripheral trigeminal system is a keystone in order to interpret the masticatory system as a complex system, and to guarantee or at least reduce the incidence of iatrogenic damage such as relapses. Figure 7 shows the success of orthodontic aesthetic follow-up 5 years, the occlusal aesthetic result is optimal, and there are no relapses. In Figure 8 we can see, in fact, the perfect symmetry of the jaw jerk and the mechanical silent period. These trigeminal electrophysiological steps will be extensively exposed and discussed during the implementation of Masticationpedia. While in this context they should only be considered in a demonstrative way. Note, in addition to the aesthetic of the smile and occlusal centricity, the perfect symmetry of amplitude of the jaw jerk, and of the mechanical silent period. Thank you for participating, and see you in the next topic, that will concern a highly debated topic, that of medical language logic.